Okay, we'll make a start and then we'll have the remaining of the participants, they will be joining us as we go through the introduction. Okay, so good evening, everybody, and thank you for joining us this evening. This is the final scheduled session of our CPD calendar. So we're very excited to invite Dr. Maya and Dr. Ala for today's topic, the social determinants of health and clinical outcomes with a focus on diabetes. Before we start today's session, I would like just to really thank everybody for participating in our CPD schedule this semester and over this academic year. We've began planning for the upcoming semester, which will be starting in fall 2022. So we'll be rejoining and restarting our CPD sessions in August, and we're really looking for your input to direct us and to inform the scheduled activities that we plan to organise for next semester. So please continue to send us your suggestions either throughout today's event or by emailing the CPD office. We always welcome your feedback and your suggestions for further topics. We're hoping as well that next semester we can bring back some face-to-face CPD sessions, and we'll be looking to communicate those to you in due course. So as always, this session is being streamed live on our YouTube channel, and both the chat function on YouTube and on WebEx will be monitored throughout. So as always, we encourage your questions and comments during today's presentation. So without further ado, and I think as more of us begin to join the session, I'd like to hand the microphone over to Dr. Maya, who will introduce today's session, and yourself and Dr. Ala. Thank you very much.
Thank you very much, Dr. Zakaria, for the introduction. Welcome, everyone. Our workshop today is, as mentioned, on social determinants of health with a special focus on diabetes. I will be first introducing my colleague, Dr. Ala Sukaria. Dr. Sukaria is an associate professor of nursing at Ali's Ramiz Shagouri School of Nursing at the Lebanese American University. She graduated from the University of Balamand in Lebanon with a BS degree in nursing and then a master's in public health from the American University of Beirut. Afterwards, she pursued her PhD studies in nursing science and research at Northeastern University, the US. Dr. Sukaria is a licensed registered nurse in Lebanon, and she is interested in diabetes self-management and cultural values, mainly diabetes fatalism. Also, Dr. Sukaria is currently tapping into understanding social determinants of health and its relationship with diabetes outcomes, which will inform nursing practice.
Thank you, Dr. Basil. I'll go ahead and introduce you. Dr. Maya Basil is an associate professor of human nutrition at Qatar University. Dr. Basil received her BS in nutrition and dietetics and MS in human nutrition from the American University of Beirut in Lebanon. Consequently, she completed her PhD in human nutrition at McGill University, Canada, then moved to the Lebanese American University as an assistant professor, and later was promoted to an associate professor before joining Qatar University this academic year. Dr. Basil is also a licensed dietitian in Lebanon. Her main research interest addresses nutrition and diabetes as part of the interdisciplinary diabetes management, with a focus on the role of the social determinants of health in diabetes care and health outcomes.
Thank you, Dr. Ala. So welcome again, everyone. The aims and the learning objective of our workshop are already on the website, so you might have gone over them. Before we start, I would like to start with the first engagement questions. What do you think are the determinants or the factors that contribute to the health of a population, or like a good health or bad health of a population? What do you think? What are the factors or determinants that determines the health of the population? What do you think they are? The main contributors, let's say. Ali mentioned GDP, only
yes.
GDP. What makes us in good health or bad health? What are the things that we go through? That's it, only GDP? Like what increases our risk of diseases? Inherited social norms. Okay, what else? Diet and genetics, absolutely. These are the most commonly studied actually factors. Exactly. But do you think, what's the number one factor? What's the most important factor? Healthcare system, exactly. So basically, interestingly, according to the, I don't know why it's not, okay. According to the Center for Disease Control and Prevention, whereby we usually and most commonly research biology, genes, behavior, education, and medical care as the main determinants of the health of the population. But actually more than 50%, and this is according to CDC, more than 50% of the health of the population is determined by the societal characteristics. So, and these social determinants actually are a hot topic that has gained a lot of attention, but mainly by the Western world, and there's a lot of research about it. And however, in our area of the world, it's still understudied. So we hope in this workshop, we're going to introduce them to you. And we're going to trigger your attention, and we're going to convince them about their importance, and about the importance not only to acknowledge them, but also to assess them and to address them later on. And this should be done in a culturally specific manner, taking our social context into consideration. When it comes to the definition of social determinants of health, again by CDC, now CDC is not the only organization that defines social determinants of health. There are so many definitions out there, and actually up till now, there's no consensus among the different professional organizations about what are social determinants of health and what are their different categories or classifications. But according to the CDC, they include the circumstances in which people are born, live, work, and age, as well as the healthcare system. And they can be categorized as the socioeconomic factors, as we all know, the psychosocial factors, so psychological and social factors, the neighborhood environment, which means the structure of the living environment, if you want, where the patient lives, and the political, economic, and cultural drivers, which I believe are the overarching determinants, are the ones at more the macro level that I think affect all the other determinants or all the other factors or all the other categories. There is also another framework that is actually the one that is cited the most in the literature, and this one is by the World Health Organization. It's a framework that also defines social determinants of health and also classifies them into levels. We have the macro level, which is mainly the socioeconomic and political context. That is more what we call the upstream factors, which include the policies, the cultural norms. This will actually affect what we call the midstream social determinants. Midstream factor like the socioeconomic status, education, occupation, income, social position, which will affect more downstream social determinants, and these include material circumstances, like the material needs, social factors, psychological factors, behavior, or even biological factors. And eventually, this will affect the well-being or the health of the individual. Now, as we can see, although there are different, as I said, levels, however, they are not separate. They are very much interrelated. As I mentioned, the overarching upstream factor will affect the downstream ones. And not only that, the downstream ones, whether it is the healthcare system, the socio-economic, the psychosocial factors, will actually feed back to guide or to inform policies and laws at more the macro level. Now, if we go to diabetes, and here I want to ask you a question as well. Why this is important specifically in diabetes? We know we have many non-communicable diseases out there, but why diabetes, out of all the non-communicable disease, is a disease that we need to really talk about social determinants when it comes to care. What's specific about the care in diabetes that is, if you want, not found much in other non-communicable diseases? Like, is it just we give a pill and the patient gets better? What does it require to achieve optimal care in diabetes?
Many healthcare professionals requires.
Absolutely. Interdisciplinary care. What else? And here I gave you some photos as, you know, good eating habits. What else? And who does the good eating habits? It's the patient who should be involved in his own eating habits.
Care is expensive,
Care is
absolutely.
expensive. Exactly. Management of stress, absolutely, Mireille. Absolutely. Education, so true. Anything else? So what I'm showing here is that, anything else, Ola?
I'm saying patient education, lifelong disease.
Lifelong disease, absolutely. It's a chronic disease. So actually, it should involve the patient, him or herself. In other words, it's not just giving a pill, go take the pill and you'll get better. It's the patient should know when to take the pill and to take it on time, especially if it's insulin. The patient should also eat well and have healthy eating habits. The patient should exercise well, and the patient, as you mentioned, should have less stress, more sleep. It's to reduce absolutely the comorbidities that are also require a lot of healthy eating and exercise. What I'm trying to say here is that it needs the involvement of the patient, him or herself, which we call self-care. Absolutely. Lifestyle and the patient self-care. So self-care in diabetes is very important. It's not enough to take a pill. The patient should be willing and involved in his or her own care. And this is what we call diabetes self-management or diabetes self-care. And this was highlighted actually in many professional and health organizations, including the American Diabetes Association in all its standards of medical care, including the most recent one, where they highlight the importance of diabetes self-management and educating the patient about that. And they stress on the importance of taking life experiences into account. And when we say life experiences, this includes the specific social context that is affected by all of these social determinants that we talked about. Also, actually, these are our collaborators, Dr. Ola and I in the States, that have developed, if you remember the WHO framework, the same framework, but specifically for diabetes. And this framework identifies the social determinants that affect diabetes outcomes. And when we say diabetes outcomes, as you all know, as health professionals, they include the clinical outcomes like glycemic control, lipid control, blood pressure. The comorbidities, as someone mentioned, or decreasing the risk of comorbidities and complication, health status and quality of life. But they identified the social determinants, whether they are socioeconomic level, psychological level, or social level, without forgetting the critical covariates like gender and age and others. These affect the health outcomes through many mediators and many interrelated factors, as we see here, by improving knowledge, improving care, improving access to healthcare, or improving the process of care. But again, all of this is a framework that was developed for the Western population. It's very important to address it in our population. Why? When we talk about socioeconomic, when we talk about policy, when we talk about social factors that are so much different in our region of the world versus the Western world. Also, as I mentioned, is a hot topic, and it was very much like research in the literature, again, in the Western population. And more recently, this is a review that was published in 2021 on social determinants of health, specifically in diabetes. This is by a group of Hill and Briggs et al. In 2021. And here they reiterate the problem with definition of social determinants of health. And there are so many different definitions out there, and there's no consensus about social determinants of health. We mentioned the WHO, but there are many others, frameworks as well, and they are classified into different classes. Some classes are overlapping, like for example, socioeconomic, right? But others are different. For example, this last Kaiser Family Foundation, they classified the food environment as a separate class, whereas it is under material circumstances in the World Health Organization, like food, or under neighborhood and built environment, according to Healthy People. So still, there is still no consensus, as I mentioned before. But this review, what they did is actually they gathered all the research about social determinants of health in diabetes in specific, and they consolidated them, and they came up with these component factors that are under these different categories. Socioeconomic status, that include education, income, occupation. Neighborhood and physical environment, that include housing, built environment. Food environment, like mainly food security. Healthcare, defined as access, affordability, and quality. And social contexts, like social coherence, capital, and support. We're gonna get to each one of them separately. Now, you might ask me, what are the psychological factors? Well, actually, these social determinants will eventually affect the psychological status of the patient with diabetes and his or her behavior, which will eventually affect his or her clinical outcomes when it comes to diabetes. Now, out of these, and this is a question for the audience, do you identify any have been mentioned here different from the determinants? No, these are actually categories of the health, the social determinants of health. And we're gonna go into each one of them in the future slide. But looking at this table, can you identify any social determinants that is applicable or relevant to people with diabetes or to any other non-communicable disease in Qatar and in your healthcare setting? Anyone can identify anything that is related to care or affects care. It could be a barrier to care or a facilitator to care. Anyone has encountered food availability?
Food availability, lots of fast food in Qatar. Absolutely.
Absolutely. This is a major barrier, actually.
Exactly.
Any other thing that you identified in your clinics or in your encounter with patients? Again, doesn't have to be patients with diabetes, could be patients with any other disease, and it has affected the care, facilitating or expensive fruit and vegetables in Qatar. Absolutely. Absolutely. Anything else? What about social factors? Lack of exercise. Very good. Yes, lack of exercise. What about social factors that might affect care, maybe again in a positive or negative way? Have you encountered anything in this regard in your clinic?
Yeah, I believe we don't have to put it as a negative spin. It doesn't have to be a barrier. Sometimes it is perceived as a facilitator.
Yes. Yes.
Family gathering
type of food. Absolutely. Very common. Again, this is like culture. Lots of advertisement of unhealthy food. Absolutely. Absolutely. Anything else? Anyway, we'll go into each one of them, and maybe when we tackle them, this will ring some bell related to your practice. So when we talk about the socioeconomic status and diabetes, so needless to say that the higher the education, and in specific the health literacy, when we say health literacy, it's when the person not only is educated about math or like has a degree, but also is literate when it comes to health, which means he or she knows about diabetes. She knows about the importance of self-care and what are the self-care behaviors and know how to apply them, right? And definitely this, again, research from the Western world has been associated with better outcomes, lower HbA1c, better diabetes knowledge, and more frequent self-care activities. Income, the poorer the income, the higher the prevalence of diabetes. Occupation, And this is actually maybe relevant to here, where the type of occupation that includes stress, long sitting times, a lot of shifting in work schedule that includes irregular working hours or job insecurity and unemployment was associated with increased diabetes risk, actually. What about neighborhood and physical environment? Where here we're talking first about housing. Unstable housing, and when we say unstable housing, this is defined as trouble paying rent, staying with friends and relatives, living in a crowded conditions, or frequent moves. Definitely this is associated with worst outcomes, because the patient cannot take care of himself, so he cannot engage in self-care or any self-management routine, cannot afford maybe diabetes or medication or supplies, and cannot find healthy food. Another component of the neighborhood or physical environment is actually, as I mentioned, the neighborhood where the person lives. And there's a lot of research about that, looking at the infrastructure, the building, the streets around them. Do you think it's easy to walk around in Qatar? Do we have open green spaces in Qatar that facilitate movement and physical activity? Because a lot of research says that better walkability in the neighborhood and access to green space is actually associated with lower risk of type 2 diabetes and better outcomes. What do you think this in terms of
There's a lack of safe pavements for walking.
Especially now with construction, right? That is everywhere. Yeah.
I would like to highlight that the weather plays its element as well, its role.
We have many parks, that's true. But as Dr. Ola mentioned, the weather might not be helpful sometimes. And also maybe this is something that, again, it is contextual, that is specific to our region. Another very important component is food environment. And one factor under food environment is food security. This is also gaining a lot of attention, not only in the Western, even here in our region. There is a lot of cars drive fast. It feels unsafe to walk in some areas. Absolutely, absolutely. So food insecurity is defined as limited or uncertain availability of and accessibility to not only any food, nutritionally adequate and safe food, which was needed, again, for proper diabetes self-care and diabetes, and inability to acquire them. And definitely this is associated with worsening diet outcomes. Why is this the case? And you mentioned it at the beginning. This is because if someone is at the lower socioeconomic status, they tend to buy cheaper food, which is usually are unhealthy, higher in energy, higher in carbohydrate and fat. Sometimes if they have like limited resources, sometimes the money or the cost of food will compete with the cost of supplies or medication. Also, sometimes the people with food insecurities, they go through phases of maybe high amount of food and low amount of food, which will lead to unpredictable blood glucose levels. So when they have high amount of food, they tend to eat a lot, which might lead to hyperglycemia. And when they have shortage, if you want, of food, this will lead to hypoglycemia. So this is common among people who are food insecure. Another component is the social context, and here it's defined as social capital, social cohesion, and social support. Social capital is more at the macro level, which means the structure, the social structure in our communities. Does it allow interaction? Does it allow connectedness? Does it allow it? And then the social coherence is whether connectedness and solidarity exist. And social support is more at the micro level, whether the patient has support from his family or his friends or his or her caregiver. And of course, again, data from the Western world shows that social cohesion, the higher and the more social support. Do you mean the social connectedness? But I didn't get the question. To encourage, yes, absolutely. This is, again, I don't know who asked this question, but this is the Western world, and here my question is gonna come after that. So social support improved health outcomes like better glycemic control, better adherence, better quality of life. Do you think in our area of the world, do we have, first of all, social support? Is it an important factor that we need to assess as a determinant? Yes or no in diabetes? It is important.
It is important.
Do you think, like in the Western world, do you think it will improve care and improve health outcomes? We actually did a research about that, and my colleague and I, and the results will be coming, and actually we'll see if it helps. Social support. Yes, social support is when you have a support from someone who lives with you, whether it's a friend or a family member who supports you in your, if you want, a fight, or in when you're taking care of yourself if you have diabetes. So you have a support. That's what we mean by social support. Support by a friend or a family. It's very common in our culture, but do you think in the Western world it helps, but do you think it helps in our culture? It's different to make this generalization. We'll see about that, because we did assess it in an Arab region, in an Arab country actually, and we'll let you know what we found out. Okay. Another important component is healthcare, and when we say healthcare, we need to check if the healthcare is affordable, accessible, and is of good quality. And of course, if all of these are available, this is inversely associated with incidence of diabetes. It's associated with better self-care and better diabetes outcomes. Now, maybe in Qatar, this is accessibility is there, but we maybe need to talk more about the quality of healthcare, especially when it comes to diabetes. Okay, I think someone is still talking about the socials. Yeah.
Yes, it is definitely an important factor, but I do not know if it is a positive or negative factor in this
I think they're still talking about the social support.
Yes.
Anyway, so another very, so talking about healthcare, there is a lot of, stress in the literature about the importance actually to provide healthcare to all, widespread coverage, and to stress on education about diabetes self-management. I just wanted to mention that. So what about us? What about the MENA region? Is diabetes a problem? Definitely. Is a public health burden. We have one of the highest prevalences in the world, actually, in the MENA region. MENA meaning Middle East and North Africa. Many countries in the GCC have a prevalence more than 12%. And actually, I was checking, the MENA region has one of the fastest increase in prevalences over the year. And these are some highlights from the International Diabetes Federation. So what about Qatar? Definitely, it's one of the most common non-communicable diseases in Qatar, and actually it's expected to rise by the year 2050. It used to be, the prevalence used to be at 16.7%, 16.7, and expected to increase to 24% by 2050. It's more common among males. And also in this article by Awad et al., they mentioned that basically the traditional risk factors are sedentary lifestyle, obesity. They stress on obesity, which is true. Obesity is the main factor that drives the increase in diabetes, especially type 2 diabetes. However, they didn't mention anything about social determinants. I'm not saying obesity is not important, but maybe social determinants might be like a barrier or a facilitator that increase or decrease the risk of obesity, which will then affect diabetes and its outcomes. Was there anything that was more common in men across the world, or is Qatar an anomaly? No, it's across the world, right? Right, Tala? Over the world, it's more common in men, diabetes.
Yes. Except that women seek more attention from medical care, which is very well known somehow.
So in the region, is it explored? Is social determinants explored? not much, as I said, it's understudied. There is a very recent article, actually in 2022, that was published in Saudi Arabia, but it was more a descriptive qualitative study. They identified the following social determinants of health in Saudi Arabia: financial burdens, familial dynamics, mental health issues, and aging population. And when they asked the primary care what hinders the action on social determinants, the barriers that were mentioned were lack of physician knowledge or training, organization barriers including time constraint, patient referral, patient cultural norms, and lack of awareness of physicians' role in managing social determinants of health. And again, this was just qualitative work. Do you identify, does anyone identify anything that is relevant to here, to Qatar? Like, do we have the same factors that, for example, hinder action on social determinants of health? What do you think? Like, there are similarities between the culture in Saudi and Qatar. Absolutely. Absolutely. And actually, I think when we talk about how we can implement social determinants of health in the section by Dr. Ola, maybe we can tackle them, these even more.
Absolutely.
So what about Lebanon? Actually, this is research from the health system are structured in a similar way. Great. So there are similar way between Saudi and Qatar. In Lebanon, this is a series of studies that I conducted actually with Dr. Ola and with our collaborators from the States, assessing the social determinants of health in diabetes, and we found the following. We have food insecurity that increases the A1C levels, so worsens diabetes outcomes, whereas commuting by walking improves glycemic control. Having higher material needs security, which reflects better socioeconomic status, and being employed leads to better A1C levels. Fatalism, this is another construct that we really explored in Lebanon, and it's very, very omnipresent in our region. And I would like your feedback about it, and if you have seen it in your patients. Fatalism is when the patient thinks that everything comes from God. You know, God brought me the disease, so God will heal me from the disease and will take care of me. No need to take care of myself. In Arabic, Ola, correct me if I'm wrong, is it the Qadariyya?
Yes.
Okay, it's the Qadariyya in Arabic. And actually, there is a specific fatalism for diabetes that we looked into, which is defined as a complex psychological cycle characterized by perception of despair, hopelessness, and powerlessness. And we did find, as it was found in the Western world, people with high diabetes fatalism had worse diabetes outcomes or higher A1C levels. So do you see that among your patients? The extent where they will refuse contemporary medicine? Yes, absolutely. Absolutely. And here it's very important to ask patients about it and assess it, and maybe later on explore ways to address it and to overcome it, because it's a major barrier to diabetes care.
Engage
family members. Yes, absolutely.
Excellent.
Absolutely. Absolutely. Now here, this is the interesting thing that I was mentioning before, social support. We measured more social support, but actually, unlike the Western world, the social support in Lebanon was actually associated with poor glycemic control. And we tried to investigate why. It could be because we have so much social support in our Arab world, so much support from our family members, that the patient becomes dependent on the family member and stop taking care of him or herself. And actually here it becomes a barrier rather than a facilitator. And here, this finding highlights the importance of assessing these determinants in a culturally specific fashion, because what applies in the West doesn't necessarily apply here. And the importance of studying the social context, or taking the social context into consideration.
Abdullah is saying that we must continue to respect the views and opinions of the patients. We cannot dismiss them. Actually, Abdullah, what you're saying is the first promising stepping stone towards implementing social determinants of health. You are absolutely right. It is a very sensitive issue.
Absolutely. What about Qatar? Actually, these are a couple of studies that I found on not social determinants of health, all of them, but mainly scattered studies here and there addressing one social determinant of health. And some of them are also qualitative study. None of them or few of them were quantitative. And in summary, what are the findings from Qatar? This is a study, the first one, it was more qualitative. They were checking the barriers mainly to medication, not to total care, mainly to medication adherence in diabetes. In addition to the common factors like age, ethnicity, and education, they did find patient-related factor that included patient individual characteristic, perception, attitude, behavior. Forgetfulness, for example, was most reported barrier. They also identified social and environmental factors like social pressure, traveling to visit friends, also as factors. Another study looked at psychological well-being in diabetes and found that age, gender, and level of education and living arrangement, so the physical environment, were significantly correlated with psychological well-being in diabetes. But in general, all of them, they reached to a common conclusion, which is we know that diabetes is mainly associated with the mainstream factors, mainly obesity, but we need to assess additional population characteristics that could be leading to obesity, that could be leading to diabetes. So this require attention. This is a common conclusion that we found in the studies, even in Qatar, and should be incorporated while developing intervention strategies. And speaking of strategies, actually, I found this Qatar National Diabetes Strategy, and the strategy included actually 6 pillars, and the pillars revolved around raising awareness, education, empowering the patient, definitely, for example, with the skills for diabetes self-care, improving care delivery, standardizing delivery across the different healthcare settings, using technology and research. But in no place in that strategy, I was reading it, there was mention of social determinants. And interestingly, this strategy would finish in 2022, which is this year. So hopefully the next strategies in Qatar to tackle diabetes would include social determinants, assess them, recognize them, acknowledge them, and hopefully also develop strategies to address them. Yes, absolutely. Okay, who mentioned that? To take findings from elsewhere to build local strategy? No, not at all. And actually, this is what's going to come next with Dr. Ola about the importance not to take findings from the Western world, because many of these constructs and many of these components are very specific to our population, to our social context, to our culture, and hence the importance of studying them in a culturally sensitive manner. So studying them in Qatar or in the Arab world, and then develop strategies to address them. And actually, this is going to be the next section. So I'm going to now leave it to Dr. Ola to continue and talking about the implementation of how we can implement social determinants in a clinical setting or in a healthcare setting. Go ahead.
Thank you, Maya, for presenting the important aspects of social determinants of health as well as the overview. My part is to dwell on framework that I have found in the literature and what can be done in this particular aspect. Definitely, this is a huge research to tap into. And as Dr. Maya mentioned, there's a lot to be done. However, it's gaining the light these days, it's gaining the attention, but we cannot adapt blindly what is done in the Western countries simply because social determinants of health is pretty much contextual in nature. I would like to mention here that in the field of medicine, it continues to operate currently in the paradigm of risk factor assessment, which means that we assess for risk factors in order to modify behavior. we oftentimes believe that it is not achieving its optimal goals simply because we're missing on assessing where the patient is coming from and what is leading to the development of the disease, that the patient is unconscious about it and not aware of it. And sometimes as healthcare professionals, we are missing on assessing it. So the call of action is typically what can be done. And as Dr. Maya said, there are not a whole lot of interventions that can inform the practice. So more and more data needs to feed in order to tailor interventions that we can relate to in our context. Next, Maya, please. Okay, so to begin with, what needs to be done in order to tackle social determinants of health? First off, we need to provide training. So it is important to create a learning environment for healthcare professionals to foster community collaborations. So we don't want to work with one arm here. We want to involve all stakeholders to optimize the population health. First off, we want as healthcare professionals to fulfill our mission in life and be lifelong learners. Hence, we want to tap into faculty development workshops that tackle social determinants of health, provide continuing education units. And this is how we can update ourselves on recent protocols, guidelines that we can incorporate in our practice to assess social determinants of health more thoroughly and comprehensively. As far as schools are concerned, an example here is the American Medical Association. They are currently evaluating medical students on cultural competency and skills on how much they can assess the patients in a culturally respectful manner. And this has been integrated in their objective standardized clinical exams. So this is how much important it is to understand the culture of the patient. So you can see here a shift from the biomedical model into incorporating the social context as well. In the curricula, it is important that we introduce social determinants of health interprofessionally. And here I would like to highlight the importance of interprofessional education, which means that whenever we want to talk about social determinants of health, it is important to offer it to all schools that are related to healthcare. So it is medicine, pharmacy, nursing, nutrition, public health, social care, all schools that can speak to that particular big umbrella of social determinants of health. And these concepts need to be introduced horizontally and vertically, which means that it is not a one-time teaching. It needs to be built up on, and it needs to be introduced in didactic courses as well as clinical courses where students get to have more hands-on experience. An example of hands-on experience is service learning. We all know that we don't want the students to go to the communities just to volunteer, contribute from their time and energy without learning from that particular community. So service learning incorporates reciprocation in education and in learning, and hence it really contributes to the development of social determinants.
There is a question they're asking, what would a culturally awareness training comprise? Briefly, like what would it include?
It's pretty much really starting with fostering the communication that is very much non-judgmental in nature. Understand that where the patient is coming from, we need to validate it without having to judge it, demean it, or even dismiss it. So just understanding where the patient is coming from is important. It's a key to unlock the norms that they believe in order to address them and hence start working on them. So that's typical startup for cultural awareness, just knowing where the patient is coming from. And this is actually a big problem for physicians who come to countries that they don't know the culture of that particular country. They face a huge problem with that because sometimes there are certain words, certain ideas that are thrown at the healthcare professional that they don't really know how to address. And in certain studies, patients tend to choose physicians who represent their cultural background because they feel more comfortable opening up to them, thinking that that particular healthcare professional can understand their, I would say, norms, the social practices, or even whatever is pulling them back from adhering to the right regimen. Can you please? Yeah. So the second part under provision of training is to prepare healthcare professionals to take action on social determinants of health. As such, as you can see here, it is important that healthcare professional institutions or associations, organizations, whether at the global or the regional level, to come together and place a framework to partner with communities. So we don't want to parachute interventions at the communities. We need to bring them to the table for them to talk about their concerns and what pulls them back from committing to proper disease management, particularly diabetes. As such, the concept of diversity and inclusion are very important in any health professional, student body, and faculty. So what I'm trying to say here is that we need to incorporate in any professional body people from minorities or underserved areas for better presentation or representation of the people who are underserved. So diversity in any entity is typically what composes that particular entity. Do we have representation from all minorities or all subgroups that we have in any population of interest? The inclusion, on the other hand, is how we are going to integrate the differences that we have into optimizing the work culture and dynamics. And these two important factors are very important to shape social determinants of health. At the end of the day, when we have diversity and inclusion, we really want to optimize health equity. So once we have diversity in the faculty or student body, as well as inclusion, we are hoping that we reach health equity that usually the people who are underserved suffer the most from. So when we have, again, this diversity, we are informing the policy making and improving the population health at large.
Ala, there is a question from Muhammad. Is there a trend whereby patients and the public, which is the service user, are becoming involved together in intervention design and development?
That is actually one requirement to have a policy making, is to involve people to design an intervention that can address the social determinants of health. But as we said earlier, interventions are scarce in the literature because we are still in the phase of collecting more data and integrating it in the conceptual frameworks. So having the right intervention is really some kind of, I would say, a gray area that the literature is still, we're still getting more data on it. So we don't really know what works the best. And as I mentioned earlier, it depends on what is important in a certain part of the world that needs to be addressed mostly. Next, please. So under the provision of training, it is believed that when we integrate social determinants of health into organizational mission and vision, it works the best because it really shapes the principles of any institution. It permeates through the culture of that institution, and it affects the deliverables of any particular institution. So that really is deeply rooted in the curriculum. It will be deeply rooted in the learning outcomes, in the overall productivity and strategic plan of any institution. So that would be really something important to adapt in order to optimize the use of social determinants of health in any particular institution. Another thing, something that one of the colleagues mentioned from the participants, is to reform communication and assessment skills. This is really when the literature stresses on the point that some healthcare professionals lack the training on how to address concerns of the patients in a culturally sensitive manner. Patients feel that they are being demeaned, demoralized, sometimes judged whenever they voice their concerns or their social norms. And we all know from our practice that sometimes we really hear odd values coming from the patients. And it's very important to look at it objectively and provide information without having to dismiss the patient's values in a radical manner. And that being said, the patient needs to feel that whenever they're coming to the clinic, it's their safe zone. Now, that being said, there's a double-edged sword thing. Physicians, for example, from the study of the Saudi Arabia mentioned that whenever they tap into addressing norms, they feel that there's a big resistance from the patients because they feel that they are being very intrusive, like sticking their nose in something that is not the right to ask. And sometimes when they go overboard and asking sensitive questions, and when we say sensitive questions, we are mainly referring to domestic violence, child abuse, and mental health. They feel that they are opening the Pandora box because they are digging into data and they feel crippled by the system that doesn't support them on tailoring interventions such as referrals or policies or laws that back them up on interventions. So for example, when a healthcare professional suspects some kind of domestic violence, if there's not any law that tells them that they have to inform a certain body or entity or the police, for example, in this case, they feel that they are crippled in the system, and this drains the healthcare professionals and it makes them feel totally unsatisfied and rather frustrated per se. Okay, so they stopped from asking this. It was a hindering factor.
So Ola, are you recommending to include this in the policies of the institution and provide procedures on how to address them, like to know and then train the health professionals on that, right?
Absolutely, absolutely. We want to provide the healthcare professionals with systems that supports their practice rather than leaving them drained. And here I would like to mention that adverse childhood experience, abbreviated as ACE, is believed to be the root cause for most illnesses. And these days it's receiving the most light or the most attention by the research and by literature or by any particular study, simply because the WHO has found that adults who suffer from adverse childhood experience a lot of problems and diseases down the road that they are not aware of. So that's why it's very important for us as healthcare professionals to tap into the norms that are believed to be normalized by the culture, but we want to break that particular taboo and start raising awareness that it is not really right to go into abuse or any particular domestic violence.
Actually, Ali is saying that actually the communication barriers are more common here than in the Western system, and this is something that needs to be addressed more. I believe.
We totally agree. Yes. Yes.
Yeah.
Next, please. Okay, so here I would like to share with you a very nice quote that Nelson Mandela once said, "If you talk to a man in a language he understands, that goes to his head. If you talk to him in his language, that goes to his heart." And in his language here means not only the linguistic part of it, but really asking questions in a very cultural competence. So this brings up how important it is to be respectful of the patient's background, even if we totally disagree with what they are saying or communicating, or it just opposes our belief system. And sometimes it's a major hazard to their life. Next, please. Okay, another aspect under the conceptual framework. So we start off by educating the healthcare professionals and train them how to conduct interviews, how to be culturally competent, integrated in the curriculum. Now we really want to standardize assessment and measurement. This is very important to facilitate the critical use and exchange of information of social and behavioral determinants of health. In the US, the following elements or variables, I would say, are mandatory to be integrated whenever assessment is done. And as you can see from these variables, they're pretty much related to the socioeconomic factor, to the race, to the financial constraints, occupation, social context, mental health, partner violence, physical activity, and stress, simply because these variables differ radically between different ethnic groups. So what works, for example, for the African Americans does not really apply for the Hispanics. And here we're still talking about the US population. And we all know how diversified the US population is. And the minorities typically suffer the most from health inequity, and hence it is important to standardize data collection and measurement, particularly related to these aspects. Next, please, Maya. Okay, so as far as adjustment of variables is concerned, currently, the American Medical Association, alongside with the United Healthcare, are supporting the creation of the 23 new ICD-10 codes. The ICD is actually the international classification of diseases that has been created by the WHO initially. It is a diagnostic tool that helps in therapeutics, in epidemiology. So it encompasses recently, what we're trying to do is to encompass social determinants of health aspect. As you can see here, it is important. They are working on integrating social aspects, not only disease-related aspects, which mainly relates to nutrition, to safe housing, transportation, medication and utilities, and caregiver needs. So you can see how these all comes under the big umbrella of social determinants of health. And here I would like to show you a YouTube on how this has been integrated into the ICD-10 codes.
One minute. It's this one, right?
Yes, yes.
The CDC, National Center for Health Statistics, have updated the ICD-10 code set with 11 new diagnosis codes describing social determinants of health. The new Z codes were created to provide additional information regarding social determinant of health data, such as housing, food insecurity, or transportation. Z codes can be used in any health setting and by any provider as a tool for identifying a range of issues related to social determinants of health. On the screen is a list of the new Z codes that have been added to the diagnosis classification. For social determinants of health, persons with potential health hazards relating to socioeconomic and psychosocial circumstances, code assignment may be based on medical record documentation from clinicians involved in the care of that patient who are not the patient's provider, since this information represents social information rather than medical diagnosis. For example, coding professionals may utilize documentation of social information from social workers, community health workers, case managers, or nurses if their documentation is included in the official medical record. Patient self-reported documentation may also be used to assign codes for social determinants of health as long as that patient self-reported information is signed off by and incorporated into the medical record by either a clinician or a provider. Check out the resources included in this course description for additional information on this topic. Please like, comment, and share this video if you found this interesting.
So you can see from this short video how important documentation is, that is not only done by the clinicians or healthcare workers, it has to be coming from all healthcare workers that really are in contact with the patient and who go over assessment in order to address social determinants of health.
Now, actually, I would like to ask the audience, do we have any documentation that assess any of these determinants when you're doing, like, when you're collecting, doing screening? It could be done by you or by the nurse or by any person in the primary healthcare center. Is there any of this that's included in the documentation or already embedded, like in the electronic system, for example? Does this exist? Any of this, any of what was mentioned? You may ask the patient if they have problems affording the medicine, and this can be recorded. So you have to ask it. It's not already embedded or integrated. It's not like there is some kind of a questionnaire that's already there, like when you ask about weight or blood pressure or stuff like that. So it's not already, you asked like an open-ended question.
This doesn't exist.
Okay. Okay. So this could be one way to integrate it into the primary healthcare
assessment.
setting. Yes.
Yes. So, so in order to integrate social needs care, as you can see, so it's not only medical care that we want to integrate, it's also the social needs that we want to integrate into the social determinants of health. Here we are referring, the literature cites the importance of integrating social workers as well as community healthcare workers alongside with other healthcare workers that can be efficiently integrated into the system. Why do we need social workers? Because the physician has a very tight time during their clinic time to
It's one of the barriers, actually, Aula. It was
Absolutely.
one of the barriers in the Saudi study. And actually, a lot of our audience would agree that the physician has a very limited time. If they have to limited time, if they have to assess it all, it's gonna be it's not gonna be feasible. Yeah.
Absolutely. So this is where the social worker's role come into the picture, whereby which the physician will be provided or the nurse will be provided with a list of referrals. And once they see that the patient is having a problem in a certain area, automatically the system will refer them to the social worker, whereby which the care will be optimized across all healthcare workers. So this is really important to highlight this the role of the social worker. When it comes to community healthcare workers, studies have shown that their role is pivotal in scheduling appointments, in follow-ups, in making sure that the patients are adhering to any kind of regimen, if they are using the referrals that they have been highlighted to efficiently. So the community healthcare workers, along with the social workers, are receiving a lot of attention, and they are being reimbursed in terms of payment. So this is a workforce that is gaining the attention from the, I would say, the US government these days, because of the recognized constraint of the primary healthcare workers in terms of time. So these are strategies that are being incorporated for screening and assessing social risk factors. So it's not primarily the role of the physician here. And also we want to incorporate social risk into care decisions. So not only we prescribe medications for the patient, we want to incorporate decisions related to social risk to make it more patient-centered, or in other words, individualized to the patient's care. It also needs to be financed. So we can't really have social workers if the role is not justified, reimbursed, and being paid for their efforts. Also, we want to fund and conduct and translate research and evaluation on the effectiveness of the implementation of social care. So once we start something new, we want to evaluate its importance. We start with the assessment, we implement, and then we evaluate in order to reflect on how the whole overall process has been working for us. Now, here I would like to show you.
Yeah, before we move to the YouTube, I just want to say something that Muhammad mentioned, which is he can see that the rapport that the healthcare professional has with the patient is important to gather this information from. So there should be a rapport first before we ask probably these sensitive questions. So maybe establish trust with the patient. So, but again, I think the healthcare professional should be trained about how to establish trust and how to communicate with the patient in a culturally sensitive, acknowledging all the norms as you mentioned, and then the trust would be gained along the way, I think.
Absolutely, absolutely. It's typically the example of the patient coming to the clinic feeling that it is their safe zone. They are not there to be demoralized or judged or dismissed for their concerns. And speaking of which, I would like to share with you another elaborative example, particularly relating to adverse childhood experience as a root cause, because it's very essential and because of the adverse consequences that it can leave to in the adult life. There is the trauma-informed care that has been implemented recently or developed recently that is thought to be improving the patient healing and outcomes. The physicians no longer are believed to be treaters, they are called healers. So this speaks again to the concept of building rapport with the patients. You can see from this example how the doctor says, instead of asking the question, what's wrong with you? They ask the question, what happened to you? When we say what happened to you, the patient feels more inclusive as opposed to finger pointing like, what's wrong with you? Okay, so with this example, you can see how this trauma-informed care has addressed or integrated every other social healthcare worker into attending to this particular issue that is very prevalent yet understudied. Maya, would you please?
I'm gonna play the video, but again, this is Muhammad saying that he agrees with us, but again, time might be a barrier, and thus we need to upskill other healthcare professionals to take on some of this role. Absolutely, and this is what Dr. Ola was mentioning by involving the social workers in screening
and training them.
And training them, exactly. So I'm gonna play the YouTube video now.
You know the old saying, don't judge a book by its cover? Well, the same is true when you assess a patient. Hi, I'm Dr. Cruz. Early in my career, I noticed a pattern with some of my patients. They often had multiple health issues, were uneasy during office visits, and frequently visited the emergency department. But worst of all, they never got better despite multiple visits. Then I realized something. From an early age, many of my patients were exposed to trauma and adverse childhood experiences, or ACEs. This includes emotional, sexual, or physical abuse, violence, neglect, discrimination, poverty, and other adverse events. ACEs are more common in the US than you'd think. In fact, 60% of US adults have one ACE, 25% have 3 or more ACEs, and 16% have 4 or more. ACEs occur in all socioeconomic groups, but are more common in low-income and minority populations. For young children, repeated exposure to trauma can impact brain development and literally rewire the brain's response to stress. So as they grow up, many struggle with issues related to emotional regulation, like depression, anxiety, or substance use disorders. Trauma survivors are also more often at risk for chronic diseases, behavioral health problems, and even suicide. Knowing all this, I began to rethink my approach to care. Instead of asking patients, "What's wrong with you?" I ask, "What happened to you?" Recognizing that life experiences are often a root cause of poor health is integral to improving patient care. Trauma-informed care has helped me take these experiences into account, providing greater insight into my patients' needs and how to address them. Here are 5 key ways that healthcare organizations can gradually integrate trauma-informed care into their practices to help patients and staff. First, build awareness and generate buy-in. Involve both staff and patients in adopting a trauma-informed approach. Second, invest in a trauma-informed workforce. Hire staff that embrace trauma-informed care and provide training not only for clinical staff, but also for non-clinical employees like front desk workers or security guards, who are often the face of your organization. Next, create an environment that is safe and welcoming for patients and staff. Engage patients in meaningful ways. Ask how they feel and listen. You can also build trust by involving them in their own treatment planning. Finally, identify and treat trauma. Consider a screening approach that works for your patients and ensure that treatments and referral sources are available. These changes take time, but each step improves our ability to connect with and care for patients. Today, our patients appreciate the changes we've made. Plus, our staff is more in tune with patients, so work is less stressful and more rewarding. Trauma-informed care. It can truly transform the caregiving experience from being treaters to being healers.
I would like to answer Muhammad's question regarding maybe there's more stigma or denial which prevents opening discussions. I would like to say that changing a culture doesn't take place overnight. It really takes multiple efforts and time to change cultural values. So it's something, it is collective efforts and a lot of collaboration that is really backed up by the system. And when I say system, it's policy formulation that can really help introducing change to the culture. So as much as it sounds like frustrating, like how am I going to start it off? We need to be patient and as they say, trust the process that it can happen if it's very well practiced or I would say assessed throughout the healthcare system consistently. So, and another question came up to my attention, which is really, is there any training tool? I would say if you browse the CDC website, it's mentioned in my in the references at the bottom side of the screen or of the slide. It will come in a bit. You will see that there's enlisted tools whereby which you can browse depending on the topic of interest. But again, there is not one framework or training tool that can be given to any healthcare practitioner. It varies with the topic. So you can see here, for example, that the trauma-informed care, this is a tool for addressing ACE. There's another tool, for example, for tobacco use in smokers. So there's no one tool per se, unfortunately. And as I mentioned earlier, and this is mentioned with Dr. Maya, that it is something that we are still exploring in terms of interventions. Next, please. Okay, so this is another great example, and I extracted that from the CDC on how documentation, proper documentation really helps with providing the best care plan for these patients, integrating social needs. So when we use the electronic health records, this is a story that came up about a patient who happens to be a medical assistant who goes to the primary healthcare clinic for follow-up about her type 2 diabetes. It turns out that her A1C is 9.5 despite reporting proper medication adherence. When the nurse was collecting data about that patient, and when I say data, it's mainly relating to her social background, information entered into the electronic health record portal about her work. She entered the data that that patient works as a medical assistant, particularly a night shift. She takes night shifts all the time. So immediately, whenever she entered that particular information, there's a pop-up box that explained to the nurse the relationship between uncontrolled diabetes and her current situation. So I would like to ask you a question here. What do you think the social determinant that is associated with the patient's uncontrolled diabetes?
Someone mentioned stress.
Yes, stress is a big factor.
What else? Irregular work pattern. Absolutely, because we mentioned that like occupation that involves a regular work pattern will increase the risk of diabetes according to literature. Yeah.
Absolutely. So the moment the nurse entered...
Absolutely, Jad. Sorry to interrupt. Absolutely, Jad, because I'm a nutritionist and I like that someone said that. Actually, you know, unhealthy eating patterns has been associated with actually working at night and like and sleeping patterns. Absolutely, that also affect the sleeping pattern are associated with actually a lot of biological and hormonal changes that increases the you know glucose. What do we call glycemic control, worsening emotional burden of working in healthcare. Emotional burden of working in healthcare. Yes.
Yeah,
this
that's true.
Is stressful and overwhelming, especially recently with the pandemic.
Yes. So I would like to say that occupation was the major cause here, particularly working in night shift. So, and this particular pop-up box did not come out of the blue. This has been guided by the literature that has found a strong evidence between irregular shifts and the uncontrolled levels of HbA1c. So hence the example on how data can really inform our practice and helps us guide us through in tailoring the right patient care for these patients. Next, please, Maya. Okay. Under integrating social needs, it is of utmost importance to integrate all stakeholders. And when I say stakeholders, I'm referring to communities, healthcare professional associations, institutions, and organizations in order to make the right decision-making and accordingly formulate the policy that works the best for all. So it is never a one-sided thing. It is always a collaboration, partnership, and teamwork. As such, something that we'd like to bring your attention to, and this is what we have noticed from our research work, is that incorporating religious organizations for emotional support is important as important stakeholders. What do you think about that particular example?
Like mainly to target fatalism, as I mentioned, where patients like don't take care of themselves because they believe this is coming from God, so God would take them. Incorporating religious organization, do you think this would be a good strategy? Community leaders, someone is saying community leaders can play an important role. Absolutely.
So as far as, believe it or not, this particular engagement of religious organizations came from a study done in the Western world. So the people who are highly religious, they do want the support that comes from the church or whatever faith they have, because it is believed to help them go through hardship that they are experiencing.
Actually, Muhammad has experienced that many patients take their direction from religious leaders.
Yeah. Well, sometimes we might be reserved in that regard because many times some patients take it in a different twist, like it is my fate, it is God's will. But we really need to use the religious figures for the best interest of the patients.
Absolutely.
Next, please. Okay. Here I would like to share the example. It's just a brief example on how the engagement of community healthcare workers was pivotal in terms of the diabetes self-management education program. So the implementation of diabetes self-education program was very successful when the community healthcare workers were engaged. They were provided training on how to go about doing the scheduling, the follow-up, referrals, use of resources efficiently. And the role of the community healthcare workers was supported by financial reimbursement. So we all know that financial reimbursement is a major motivator for people. And it is believed that they were doing the grassroots work to connect healthcare settings together. And they served as liaison, I would say, between diabetes educators and community members, particularly in those of the marginalized communities. So we know that community healthcare workers build rapport with community members earlier than the physicians, simply because they are in touch with them probably more frequently than healthcare providers, the rest of the healthcare providers. Next, please, Maya. Okay, so last but not least, it is important to look at policy. As you can see here in this picture, the role of the government is to put the pieces of the puzzle together to come up with a policy where we have consistency in the application of the recommendation that healthcare members believe might work in the context of social determinants of health. As such, as per the WHO recommendation, it is important first from the government to improve the daily living conditions, particularly with early childhood education, because we have seen how adverse childhood experiences can leave detrimental consequences on our health as adults. Improve living conditions and working conditions. Like, for example, if we need to have more green spaces, the government has to fund and support such projects. Create social protection policies supportive of all, particularly when we suspect domestic violence. There needs to be social protection policy for the healthcare professional to go about and go all the way in the assessment and do the right referrals or take the needed aggressive actions in this particular topic.
Sorry, Ola, sorry for interrupting, but there is a question related to the previous slide, which is if we can elaborate on how we can involve religious leaders do they develop guidelines? Are they involved in developing guidelines? I don't think so.
Their role is more of supportive figure, we would say. Now, this is definitely a great question because the role hasn't been explored yet, but it is found in the literature that they do provide a whole lot of social support. So when patients are in a deep emotional constraint or they're suffering from any emotional drain, they go to the religious figures for support. So when we engage
actually,
religious figures...
Actually, Hamid, I forgot to mention, he's like some patients take the work of their imam as sacred.
Yes, yes. This is what I'm trying to say, that sometimes we don't want to put it in a spin where they believe not they believe every single word, but I would say they want the religious figures to work on the side of the healthcare professionals. So, for example, in the case of diabetes fatalism, Maya and myself thought that one major intervention would be in our interventional study is to have a religious figure talking about how important it is to isolate a disease from fate. So it's not God-sent disease. Diabetes is not God-sent disease. It is not a fate. It's something that people can work on because because we are typically not totally guided by God's, I would say.
And actually, God would help people that help themselves, and God actually provided knowledge and provided skills through healthcare professionals to facilitate people taking care of themselves and improving their well-being and improving their health. This is the approach that we're still exploring, as Dr. Ola just said, and we would like to actually incorporate in our future interventions in order to address fatalism in particular.
Absolutely. Absolutely.
Yes.
Okay.
So go on. Sorry, Dr. Ola, for interrupting.
No problem. So, tackling the inequitable distribution of power and money, and this comes the role of the strong public sector that is committed to distributing the power and the money and the resources equally among all populations. So this means that the marginalized and the people who are underserved, they need to benefit the most from these resources in order to achieve health equity per se. Next, please, Maya.
Yeah, 1 minute. Yes.
Okay, so once we implement a policy, it is important to measure and understand the problem and assess its impact. So this means that we need to always have surveillance system. It's not a one-time shot that we implement and forget about it. We always have to have collecting data to give us feedback on how well we are doing in terms of the policy implementation, evaluate how well we have delivered in terms of resources and money and services to the people who are underserved, particularly achieving health equity to those who are underserved or to the poor communities. And we also want to cultivate health resources, social sciences, and mainly make good use of interdisciplinary research for advancing social care in this regard. So an example here, and something that we all know is happening in this part of the world, is the constraints of practitioners in primary care practice. We all know that they suffer from tight consultation time, overloaded, and lack of follow-up, and as well as scarcity of general practitioners. How do you think this problem can be solved with the integration of policy? What do you think? What is the policy that can work to support the practice of the general practitioners?
Muhammad is saying involving other healthcare professionals.
Absolutely. Can you please specify how do you think we can involve them? And who are these healthcare professionals?
Miriam is saying using IT as
Yes.
well to support
documentation and data entry. Yes. Appointment system.
We can, yeah, the appointment system. Technicians and assistants, Muhammad is elaborating.
Okay. So this has been cited actually by the Saudi doctors, the primary care physicians, who highlighted the role of the nurse in doing the triage and the assessment. The general practitioner doesn't have the time to do all the assessment, and they need to be provided with the references or the referral list in order to refer the patients to the social workers whenever they perceive that there's a social need as such to address social determinants of health.
Yes, apparently there is a software or like a platform called eHealth here that can be used as a facilitator.
Yes, electronic documentation, just like the example that I shared on the pop-up box.
Yes, absolutely. And it actually can identify them like through the system.
Yeah. Next, please. Okay. And it goes without saying that whenever the government starts funding research to deliver and to study the effectiveness and implementation of social care practices, as they say, the research will keep coming, data will keep flooding in, and this will inform our practices better off. So a big example on this is, I'm not sure if you are aware of the diabetes prevention program that is done in the US. This program helps people who are at risk of diabetes to enroll themselves in this program. And this program, predominantly by most of the US states, it is totally covered by the government, that is supported by the CDC, Medicaid, Medicare, among other third payers like insurance companies, whereby which the patients enroll themselves in this program that is 12 months long, and it has very promising outcomes in terms of clinical outcomes as such. So some, for example, some other states have taken extra measures per se, just like Maryland and Oregon, and they have provided additional strategies such as the provision of transportation for these patients, as well as childcare, to encourage the biggest number of patients to be enrolled in this particular program. So this is a very good example on how policy can support the implementation of programs successfully and consistently, and how it can improve the population health ultimately.
Absolutely.
Next, please, Maya.
Yeah, we're done.
There's also one, I think. Oh, okay. All right.
Yes. I just wanted to share something from the chat, which is Abdullah, telephonic triaging may also help to reduce the burden on family physicians.
Yeah, that's really the role of the community healthcare workers that has been documented in the literature. Or sometimes the social workers can do that. So as far as we are really distributing the work across healthcare members, this really helps in addressing the social determinants of health holistically.
I think you mentioned the one on the research that's still lacking, Ala?
Yeah. You mean, yes, the slide on research.
Yes, I don't know where it's going.
I can brief the audience.
You can brief us on it.
Yes,
So there is still research that's lacking, of course, especially in our in this region of the world. Yeah.
So what has been recommended? What can we do as in terms of research? First off, research is more needed in terms of unifying the terms used for social determinants of health. What are the tools, as one of you have asked? How can we measure social determinants of health? More research is needed in this particular matter. Also, more research is needed to study how social determinants affect certain populations more than others as either facilitators or barriers, and this particularly applies to countries that have different ethnic backgrounds. So this helps the healthcare workers on how to approach these particular subpopulation or minorities per se. I would like to say that Dr. Maya and I are currently engaged in social determinants health that is funded by the National Institute of Health in the US with our US collaborator. What we are studying is a partnership with the US, it's with the academic institutions, and this is highly supported with research because more research needs to engage academic institutions in order to study social determinants of health, and doesn't stop here. We really want to take it to the interventional level where more studies can be brought to the light.
Which might also guide policymakers.
Absolutely, it all favors policy making at the end of the day.
Yes.
We don't want research that sits on the shelf.
Absolutely. Thank you very much, Dr. Ala, for this very informative session of yours. Thank you all for sticking around until this time. Do you have any questions to any one of us? I would just like to mention Dr. Zakaria actually sent me a comment, and he mentioned that he was involved in a study in the UK actually to understand the Muslim communities and their medication taking behaviors, and it was interesting to find out that the patients often take the guidance on this matter from their local imam, and this is again to highlight the importance of involving maybe religious leaders in any intervention.
We have had patients who have supported they justified, I would say, their humongous intake of dates, tamar, by referring to the Quran. But, you know, with the Quran, it doesn't specify the amount. So there's always an excuse for them by supporting it with the, I would say, religious resources. So we thought, again, the religious figure will help us or help the researchers in really being very specific in terms of recommending food or practices per se, and not to be misinterpreted.
Abdullah also mentioned something about how we can reduce the load on the physicians is to do telephonic triaging. May also help to reduce the burden on family physicians. So he mentioned that as well. So that's it, ladies and gentlemen. Any other question, comment?
Just as our participants are looking to add their final questions, I want to give a big thank you on behalf of the CPD department here at QU Health. Very interesting presentation and very well delivered. Thank you very much, Dr. Ala and Dr. Maya. And we'll be very interested to invite you back once you have some results and analysis of your research. I think it'll be very, very relevant to our participants. So we look forward to hearing further on this topic.
Looking forward to that.
Thank you for the audience for raising these interesting questions.
Yes.
Thank you for the
Again,
invitation.
we hope, we know this is something maybe that's new. It's there, but maybe not addressed in a structured manner. We hope we have triggered your attention, and we hope that you're gonna go back to your practice and try to incorporate it in one way or another in your practice.
Small steps but big rewards at the end of the day.
Yes, because of as we mentioned, its importance in affecting health outcomes. Thank you, everyone.
Thank you.
Thank you very much, everybody, and we look forward to seeing you again soon. Thank you. Good night.
Thank you.
Bye-bye.
Bye.